Welcome to this module on double outlet right ventricle. Two different diagnostic criteria are used. One will be the override criteria, where one of the great artery and more than 50% of the other great artery should arise from the right ventricle to call the morphology of the lesion as double outlet right ventricle. In the second criteria, presence of bilateral conus, that means a conus below the aortic valve and a conus below the pulmonary valve, is important for the diagnosis of double outlet right ventricle. The presence of conus below both the aortic and pulmonary valve will lead to fibrous discontinuity between the semilunar valves and the atrioventricular valves. The morphological subtypes of double outlet right ventricle are based on VSD location and the relationship of the great arteries. Based on VSD locations, double outlet right ventricles are classified into those with subaortic VSD, those with subpulmonary VSD, and those with doubly committed VSD, which means the VSD is related both to the aortic and pulmonary valves, and those with remote VSD, which means they are both away from the aortic and pulmonary valves. They are classified based on the relationship of great arteries as normally related great artery, side by side great artery relationship where the aorta is to the right and pulmonary artery is to the left, and D malposition, which means the aorta is either right and anterior or entirely anterior to the pulmonary artery, and L malposition, which means the aorta is left and anterior to the pulmonary artery. We will move on to multiple illustrative examples of double outlet right ventricle with the various morphological subtypes. We will start with one of the commonest type, the double outlet right ventricle with subaortic ventricular septal defect and normal great artery relationship. When we say normal great artery relationship, we mean the pulmonary artery is left and anterior and the aorta is right and posterior as in a normal heart. On a subxiphoid short axis view, we can see the right ventricle occupying the left side of the screen, the left ventricle occupying the right side of the screen. We can see the aorta coming off from both the ventricles. We notice that there is an aortic override of around 60% of commitment of the aorta towards the right ventricle. There is a small area of aortomitral fibrous discontinuity. On a leftward sweep on the same subxiphoid view, we can appreciate the pulmonary artery arising entirely from the right ventricle. So here the pulmonary artery arises entirely from the right ventricle and around 50 to 60% of the aorta is also arising from the right ventricle. When we see on a coronal plane, we can appreciate both the great arteries arising from the right ventricle. 3D echocardiogram will help in understanding of these conotruncal defects far better. In this 3D en face view, we are visualizing the right ventricular surface of the interventricular septum. We can notice the aorta and pulmonary artery arising from the right ventricle. We can appreciate a large ventricular septal defect noted immediately below the aortic annulus. Let us analyze this subaortic VSD more carefully. We can see in this subxiphoid short axis view the aorta arising from the right ventricle and partly from the left ventricle. 50% of the aortic valve is committed to both the ventricles. We can notice a large subaortic ventricular septal defect. There is a thick subaortic conus that is separating the anterior mitral leaflet from the aortic annulus. On a further sweep towards the left side on the same subxiphoid short axis view, we can appreciate the pulmonary artery arising entirely from the right ventricle. Since the ventricular septal defect is in subaortic location, we are not able to see the ventricular septal defect at all when we see the pulmonary outflow tract. In this clinical example, when we do the 3D echocardiogram and crop off the entire right ventricular anterior free wall, we visualize the interventricular septum, the right ventricular aspect en face. We can appreciate a thick septal band on the RV septal surface. You can see the tricuspid valve. You can appreciate both the great arteries, aorta and the pulmonary artery, with the valvar structures. The aortic valve and the pulmonary valves are seen clearly. The ventricular septal defect is clearly located in close relation to the aortic valve, immediately below the aortic valve. On a still frame, we can appreciate that the right ventricular septal surface is showing the thick septal band. At the upper end of the septal band, you can see the horizontal divisions of the septal band, and the ventricular septal defect is sitting on that cradle. It's located immediately below the aortic valve, and it is far away from the pulmonary valve. The adjacent cartoon also demonstrates the subaortic ventricular septal defect. Double outlet right ventricle with subaortic VSD is one of the commonest type of double outlet right ventricles. We will see another example wherein there is an additional inlet muscular VSD. About 10 to 15% of double outlet right ventricles will have additional muscular VSDs. In this parasternal long axis view, we appreciate the left ventricle and the right ventricle. The aortic valve is clearly seen. There is a 60% aortic override towards the right ventricle. There is a small aortomitral fibrous discontinuity which will represent the subaortic conus. On a subxiphoid short axis view, we can appreciate the large subaortic VSD. We can appreciate that the aortic annulus is almost around 60 to 70% committed towards the right ventricle. There is also a large inlet muscular ventricular septal defect between the tricuspid and the mitral valves. When we use color Doppler, we can appreciate the flow of blood through the inlet muscular ventricular septal defect. We can notice the red color of the blood coursing from the left ventricle towards the right ventricle through that inlet muscular VSD. On these two still frames, we again show that additional inlet ventricular septal defect. On the left, you see the subxiphoid short axis view, and on the right, you see the apical four-chamber view. Both demonstrate an inlet muscular ventricular septal defect. When we do a three-dimensional echocardiogram and see the RV septal surface en face, we are able to appreciate the additional inlet muscular VSD located among the trabeculae from the septal tricuspid leaflet. Two small stars are placed, one on the subaortic conotruncal VSD and one on the inlet muscular VSD. On the still frame, the two stars show the subaortic ventricular septal defect and the inlet muscular ventricular septal defect. This is the RV septal surface seen en face on three-dimensional echocardiogram. The aortic override in patients with double outlet right ventricle and subaortic VSD can vary from 50% to almost 100%. In this subxiphoid short axis view, we can see that the aortic valve is committed equally to both the left and right ventricle. This will mean 50% of aortic override. When we sweep leftward towards the pulmonary artery, we can see that the ventricular septal defect is not visualized. So this is a subaortic VSD with 50% aortic override. The parasternal long axis view again shows that the aorta is committed 50% to both the right ventricles and left ventricles. There is a 50% aortic override. We can also appreciate the aortomitral fibrous discontinuity or subaortic conus. On parasternal long axis view, when we visualize the pulmonary outflow tract, the ventricular septal defect is not seen, indicating that the VSD is related clearly towards the aortic valve. We will demonstrate another double outlet right ventricle where there is almost 90% of override of the aorta. On this parasternal long axis view, we can appreciate that the aorta is almost 90% committed towards the right ventricle. There is a thick subaortic conus shown as aortomitral fibrous discontinuity. When we do a color Doppler interrogation, we can notice the flow from the left ventricle towards the aortic valve. We can see that the size of the ventricular septal defect is marginally smaller than the size of the aortic annulus. So this is a very minimally restrictive ventricular septal defect. On a further lateral sweep in the same patient, we can notice the pulmonary valve. We can see some mild subvalvar and valvar pulmonary stenosis, and the pulmonary annulus is smaller than the aortic annulus. On a color flow imaging, we can notice the turbulence in the pulmonary outflow tract, which indicates the subvalvar and valvar narrowing. Pulmonary stenosis is quite commonly seen in many patients with double outlet right ventricle. We can also notice that there is a small coronary artery that is crossing the pulmonary annular region, which is shown as a flashing small red parallel track immediately anterior to the pulmonary outflow tract. On a parasternal short axis view, we see the dilated aortic root, the narrowed pulmonary outflow tract, which is shown by a turbulent color flow signal. The aortic root is dextro-rotated, and so the left coronary artery is arising almost from the posterior aortic sinus. We can notice that the large left coronary artery is giving off the right coronary artery, which courses anterior to the right ventricular outflow tract from left to right. If you carefully observe the pulmonary outflow tract, immediately anterior to that you can see a parallel track which is showing flashes of red color. So here the right coronary artery is coursing anterior to the right ventricular outflow tract and crossing across the RVOT. This coronary anomaly will prove to be an impediment in doing a right ventricular outflow tract resection from the anterior wall of the RV. We will not be able to put in an RVOT or a transannular patch when a large right coronary artery is crossing anterior to the right ventricular outflow tract. In the previous example, we saw a double outlet right ventricle with almost 90% aortic override. We'll show patients with more degrees of override. This will be described as 200% double outlet right ventricle because 100% of the aortic valve and 100% of the pulmonary valve are committed towards the right ventricle. On a subxiphoid short axis view, we can notice the aortic valve from the right ventricle. The entire aorta is committed towards the right ventricle, and we can notice a large subaortic ventricular septal defect. On a parasternal long axis view, again, we can appreciate that the aortic annulus is completely committed towards the right ventricle. There is a lot of distance between the ventricular septal defect and the aortic valve, and there is a large separation between the aortic annulus and the mitral annulus. When we sweep to the left on the same parasternal long axis view, we can appreciate the pulmonary valve and the main pulmonary artery. Once again, the pulmonary artery is 100% committed towards the right ventricle. On a parasternal short axis view, we can notice the aorta and pulmonary artery with a side-by-side relationship. This side-by-side relationship where the aorta is to the right and pulmonary artery is to the left is one of the commonest great artery relationship in double outlet right ventricle. Whenever the aorta and the pulmonary artery are 100% committed towards the right ventricle, the intraventricular tunnel repair, where the VSD is routed towards the aortic valve, will involve a very long patch, sometimes multiple patch. This is an example of a modified apical view where the left ventricle has been routed towards the aortic valve with a long patch. On a color flow imaging, there is no obstruction to the left ventricular outflow tract now created by the long intraventricular tunnel patch. However, there is trivial aortic incompetence. We need to understand that in double outlet right ventricle with subaortic VSD, all the ventricular septal defects will not be located immediately below the aortic valve. In some patients, they may be anatomically be separated from the aortic annulus by a long conal septum. We'll see one example of a double outlet right ventricle with a remote but conotruncal VSD associated with a long muscular conus. This is a parasternal view of a patient with a double outlet right ventricle. We are able to see the tricuspid valve, the right ventricle and the aortic valve. In fact, the left ventricle is not shown here at all, and so the VSD is also not shown. On a subxifoid short axis view, we are able to appreciate the aorta arising from the right ventricle. On a leftward sweep, we can appreciate the large dilated pulmonary artery. However, the ventricular septal defect is seen far below. There is a long conal septum that is seen even below the pulmonary valve, separating it from the ventricular septal defect. On a subxifoid coronal sweep, we can appreciate both the great arteries arising from the right ventricle and their normal great artery relationship, which means the aorta is right and posterior and pulmonary artery is left and marginally anterior. On a parasternal long axis view here, we see the pulmonary outflow tract. However, the ventricular septal defect is not shown well at all. On a parasternal short axis, we can appreciate the normal relationship of the great artery, where the pulmonary valve is left and marginally anterior. On a parasternal short axis view, we can appreciate the normal relationship of the great artery, where the pulmonary artery is left and marginally anterior. We can also appreciate a normal crossover of the great arteries. The main pulmonary artery is wrapping around the aorta on its left side. When we do a 3D reconstruction, we can see the RV septal surface seen en face. We can see the subaortic ventricular septal defect. However, the ventricular septal defect is not immediately below the aortic valve. It is separated by a long subaortic conus. The dotted region shows the imaginary patch that has to be placed from this ventricular septal defect's margin towards the aortic annulus to achieve an intraventricular tunnel closure of this VSD for a biventricular repair. We will move on to another example of a double outlet right ventricle with a subaortic VSD where there is a posterior inlet extension. On a parasternal long axis view, it appears as the aorta is committed 90% towards the right ventricle, about 10% towards the left ventricle. There is a long aortomitral fibrous discontinuity. However, in this view, it looks like the ventricular septal defect can be used to route the left ventricle into the aorta. When we do an apical 4-chamber view, we appreciate that the ventricular septal defect has got an inlet extension and the tricuspid valve is overriding and straddling this ventricular septal defect. What we mean as overriding is a portion of the tricuspid annulus seems to be committed towards the left ventricle. If you draw a line along the interventricular septum and take it up to the tricuspid annulus, we can see that about 60 to 70% of the tricuspid annulus is committed towards the right ventricle, but around 30% of the tricuspid annulus is committed towards the left ventricle. We can also notice that some of the tricuspid valve chordae are crossing over towards the left ventricle. This is called straddling of the tricuspid valve. On a subxiphoid short axis view, we can notice the aortic valve, a large subaortic ventricular septal defect. We can see the tricuspid valve and the mitral valve, but if we carefully look at the caudal attachment of the tricuspid valve, we can see that some of the tricuspid valve chordae are coursing through the ventricular septal defect and getting inserted in papillary muscles which are located on the inferior posterior wall of the left ventricle. This will represent a grade 3 straddling of the tricuspid valve tissue towards the left ventricle. When we do a 3D reconstruction, we can appreciate the right ventricle and the left ventricle on the left side of the screen and the right side of the screen. The moving structures are the tricuspid valve leaflets and the mitral valve leaflets. We can notice the tricuspid valve chordae getting attached towards the posterior inferior wall of the left ventricle, representing the grade 3 straddling. This is a three-dimensional view of the left and the right ventricle. We have cropped off the entire apical and mid portion of the right and the left ventricle to show the basal portions of the left and right ventricle. We can notice the mitral valve and the tricuspid valve apparatus. The tricuspid valve chordae are seen to cross over the ventricular septal defect towards the posterior and inferior wall of the left ventricle. The two arrow marks show the anterior and posterior margins of the ventricular septal defect. Even though the ventricular septal defect is subaortic, we will not be able to route this left ventricle towards the aorta with a VSD patch without disturbing this tricuspid valve apparatus, which is straddling into the left ventricle. So far, we had been seeing double outlet right ventricle with subaortic VSD, which is the commonest location of ventricular septal defect. When we say subaortic, it doesn't mean all the VSDs will be located immediately below the aortic annulus. Some of them may be located a little bit more remote from the aortic annulus and separated by a long subaortic conus, however, can be routed towards the aortic valve. Now we will move on to examples of double outlet right ventricles with subpulmonary VSDs. On this subxiphoid short axis view, we can notice the right and the left ventricle and a large subpulmonary VSD. The pulmonary valve overrides the ventricular septal defect. There is a 50% commitment of the pulmonary annulus towards the right ventricle. A double outlet right ventricle with a subpulmonary ventricular septal defect, where the pulmonary artery is going to override the ventricular septal defect, is called as the Taussig-Bing anomaly. On this parasternal long axis view, we appreciate the large dilated pulmonary artery and the pulmonary annulus. There is an override of the pulmonary artery. 50% of the pulmonary valve is committed towards the right ventricle. We can also notice that there is a pulmonary mitral fibrous discontinuity. Anterior to the pulmonary artery, we can see the aortic annulus also. There is a marked discontinuity between the aortic annulus and the mitral annulus. In the previous example of double outlet right ventricle with subpulmonary VSD described as Taussig-Bing anomaly, we found that the pulmonary artery was overriding the ventricular septal defect about 50%. Let us see another example where there is more marked pulmonary artery override, almost to around 90%. In this subxiphoid short axis view, we can notice that more than 90% of the pulmonary artery is arising from the right ventricle. There is a small pulmonary mitral fibrous discontinuity. On an anterior sweep, we can appreciate the aorta arising from the right ventricle. The entire aorta is arising from the right ventricle. So here, the entire aorta and more than 90% of the pulmonary artery is arising from the right ventricle. On a parasternal short axis view, we can notice that the aortic annulus, which is smaller, is located left and anterior to the dilated large pulmonary outflow tract. So this is an L-mal post aorta. Among the various types of malpositions, D malposition and L malposition are commonly seen in Taussig-Bing anomaly. Double outlet right ventricle with large subpulmonary ventricular septal defect will need an arterial switch operation and a VSD closure. When the VSD is closed, the left ventricle will be routed towards the pulmonary annulus, and subsequently when we do an arterial switch, we will be able to commit the left ventricle towards the neo-aorta. So in all patients with Taussig-Bing anomaly, double outlet right ventricle with subpulmonary VSD, coronary arteries needs to be defined very clearly, since coronary transfer is an integral part of arterial switch operation. In this example, we can notice that the aortic valve is located left and anterior to the dilated pulmonary artery. The two coronary arteries, namely the right coronary artery and left coronary artery, both arise from the right and posterior facing sinus. We can notice that the left coronary artery, which is arising from the right posterior sinus, is having a small intramural course and courses between the aorta and pulmonary artery to emerge on the left side of the aorta and branch into a large left anterior descending and small left circumflex arteries. The origin of left coronary artery from the right posterior sinus of the aortic valve, its course between the aortic root and the pulmonary root, and sharing of the wall of the left coronary artery in its proximal portion with the wall of the aortic root are hallmarks of intramural left coronary artery. This intramural left coronary artery is going to create problems for performance of an arterial switch operation in this patient with DORV with subpulmonary VSD. So when there is a coronary artery abnormality which will pose a higher risk for performance of an arterial switch operation, we need to explore the ways of routing the ventricular septal defect towards the aortic annulus. On this subxiphoid short axis view, we are able to see the aortic valve, a subaortic conus that is extending below the aortic valve, and the ventricular septal defect. On a subxiphoid coronal sweep, we can appreciate the left and anterior aorta, right and posterior pulmonary artery. The pulmonary artery is markedly dilated. On a 3D en-face view of the right ventricular septal surface, we can appreciate the large subpulmonary VSD located immediately below the pulmonic valve. The aorta is left and anterior. If we need to route the ventricular septal defect towards the aortic annulus, this will need a long intraventricular tunnel patch from the margins of this ventricular septal defect towards the aortic annulus. Because of intramural coronary arteries which pose a problem for performance of an arterial switch operation, routing of this ventricular septal defect to the aortic valve through a long intraventricular tunnel should also be considered as one possible surgical option. The 3D en-face view of the right ventricular septal surface shows that the ventricular septal defect is very closely related to the pulmonary artery. However, it can be routed with a long tunnel towards the aortic annulus, which is located left and anterior to the pulmonary annulus. This 3D view clearly shows the aortic valve leaflets and the aortic root. Even though the ventricular septal defect is located immediately below the pulmonary outflow tract, we can see that with a long intraventricular tunnel, we will be able to achieve a closure of this ventricular septal defect and route the left ventricular blood towards the aortic annulus. The presence of subvalvar and valvar pulmonary stenosis in the setting of double outlet right ventricle with subpulmonary VSD has more significance. The usual conventional treatment of double outlet right ventricle with subpulmonary ventricular septal defect will be performance of an arterial switch operation. If there is a pre-existent subvalvar and valvar pulmonary stenosis, this is going to cause a neo-aortic subvalvar and valvar stenosis, and hence they will need to be defined far more clearly. Subxifoid short axis view shows double outlet right ventricle with a large subpulmonary ventricular septal defect. We can notice the turbulence in the subvalvar pulmonary outflow tract. On an apical view, we can notice that the pulmonary annulus is almost 100% committed towards the right ventricle, and there is a subvalvar and valvar pulmonary stenosis. On a parasternal long axis view, we can again notice the 100% commitment of both the aortic and pulmonary annulus towards the right ventricle, mild narrowing of the subvalvar pulmonary outflow tract, and mild doming of the pulmonary valve as well. It will be interesting to note the utility of three-dimensional echocardiogram in double outlet right ventricle in subpulmonary VSD. In the previous few examples of double outlet right ventricle with subaortic VSD, we illustrated the additional information obtained from 3D echo. Let us see in this subpulmonary VSD. On this subxifoid short axis view, we can notice the aortic valve arising entirely from the right ventricle and a large ventricular septal defect. On a three-dimensional echocardiogram, we have cropped off the entire apical and mid portion of both the right and the left ventricle, and we are visualizing the basal portions of the right ventricle and part of the left ventricle from below. We can notice that the aortic valve is seen far anteriorly and the pulmonary large annulus is seen posteriorly. We can see the large subpulmonary ventricular septal defect. The aorta is quite far away from the ventricular septal defect. In this 3D echo, the apical and mid portion of the right and left ventricle have been cropped off, and we are visualizing the basal portions of both the ventricles from below. The two arrows point to the region of the ventricular septal defect, and they are very closely related to the pulmonary valve structures. The aorta is far more anterior. On this 3D echocardiogram, right ventricular en-face septal view, we can notice the large subpulmonary ventricular septal defect, the dilated main pulmonary artery and the pulmonary annulus shown clearly on the interventricular septum. This delineation of the right ventricular septal surface, unfast by cropping off the entire right ventricular anterior free wall, will help in understanding the location of the ventricular septal defect in relation to the great arteries. We can clearly appreciate a large ventricular septal defect located in the cradle formed by the two horizontal divisions of the septal band and located below the pulmonic valve. The aortic valve is not seen in this view because the aorta is far more anterior. So far we had discussed double outlet right ventricle with subaortic and subpulmonary ventricular septal defects. Let us move on to remote types of ventricular septal defects, especially those in the inlet septum. In this subxiphoid short axis view, we can notice the right and the left ventricle. The aorta is originating from the right ventricle almost 100%. We can see that there is a large inlet ventricular septal defect that is located between the tricuspid and the mitral valves. When we carefully visualize the tricuspid valve caudal tissues, we can see some of the anteroseptal caudal tissues getting attached towards the conal septum immediately below the aortic annulus. This subxiphoid view clearly indicates that the ventricular septal defect is located between the aortic and the pulmonary valves. So this inlet ventricular septal defect is far remote from the aortic annulus. We can also notice the long conal attachment of the tricuspid valve chordae, which will come in the pathway of left ventricle to aorta tunnel. When we do a 3D en-face reconstruction, by cropping off the apical and mid portion of the right and the left ventricle and visualizing the ventricular side of the basal portions of the right ventricle, we can notice the tricuspid valve chordae getting attached towards the subaortic conal muscle. It will be very difficult to route this ventricular septal defect towards the aortic valve without injuring all these tricuspid valve caudal tissues. On this 3D view showing the basal portions of the right ventricle and part of the left ventricle, the two arrows point to the location of the inlet ventricular septal defect. The tricuspid valve caudal tissues are attached to the subaortic conus, named as the conal muscle of Lancisi. We can appreciate that the left ventricle to aorta tunneling will be seriously disturbed by the presence of these caudal structures. If we have to draw a hypothetical tunnel from the left ventricle towards the aortic annulus, as shown in this picture, we will notice that the tunnel will be causing a substantial injury to this tricuspid valve leaflet and caudal structures. And hence, in this remote inlet ventricular septal defect, a biventricular repair by routing the left ventricle towards the aortic annulus will not be feasible. In another example of a double outlet right ventricle with a remote inlet ventricular septal defect, where there was an anterior aorta and a posterior pulmonary artery, a biventricular repair was feasible by routing the VSD towards the posterior pulmonary artery. In this subxiphoid short axis view, we can notice both the great arteries, aorta and pulmonary artery, arising exclusively from the right ventricle. There is a large inlet ventricular septal defect between the mitral and the tricuspid valve apparatus, as shown by two arrows. We can notice that even though the ventricular septal defect is in inlet location and located between the two AV valves, the posterior pulmonary artery is also reasonably in close relation to the ventricular septal defect. On this subxiphoid short axis view, we can see the tricuspid and the mitral valve opening. The large inlet ventricular septal defect is seen clearly. Portions of the tricuspid valve chordae are getting attached to the conal septum that is protruding below the aortic and pulmonary annular area. However, when we conceptualize a pathway from the left ventricle through the ventricular septal defect towards the pulmonary outflow tract, there are no caudal structures from the tricuspid valve which are crossing into the way of left ventricle to pulmonary annulus tunnel. On a parasternal long axis view, we can notice 100% commitment of the aortic and pulmonary valve to the right ventricle. We can notice a large inlet ventricular septal defect and portions of the tricuspid valve leaflets on the right ventricle. When we do a 3D reconstruction, crop off the apical and mid portions of the right ventricle and part of the left ventricle and visualize the basal portions of the left ventricle, we can appreciate the large inlet ventricular septal defect between the tricuspid and mitral valve apparatus. We can see the pulmonary and the aortic outflow tracts. There is a clear pathway that can be used for routing the ventricular septal defects towards the posterior pulmonary outflow tract. The imaginary tunnel from the left ventricle through this inlet ventricular septal defects towards the pulmonary annulus is shown by two arrows. We can appreciate that even though the tricuspid valve caudal apparatus are attached to some portion of the conal septum that is protruding below the aortic and pulmonary annulus, this will not impair the performance of a left ventricle to pulmonary artery routing. And if we perform an arterial switch operation, that will complete a biventricular repair in this clinical example. We notice a very clear pathway from the inlet ventricular septal defect towards the posterior pulmonary outflow tract, which will permit an intraventricular tunnel closure of the ventricular septal defect towards the posterior pulmonary annulus and completion of a biventricular repair by an arterial switch operation. Now we will move on to some examples of double outlet right ventricle with remote inlet ventricular septal defect, where a biventricular repair is feasible by routing the ventricular septal defect towards the aorta. In this modified subxiphoid view, we can appreciate a large remote ventricular septal defect between the left and the right ventricle, and the aortic annulus is seen far more anteriorly. There is a very long subaortic conus and a long area of aortomitral fibrous discontinuity. We can notice that the separation between the aortic annulus and the mitral leaflets is extremely long. This ventricular septal defect is a very remote ventricular septal defect. However, when we visualize a left ventricle to aorta pathway for closing the ventricular septal defect using a long patch, it seems feasible because there are no caudal structures of the tricuspid valve that are crossing this pathway. On a parasternal long axis view, once again we can appreciate the anterior aorta and a long separation between the ventricular septal defect and the aortic annulus. There is a very long aortomitral fibrous discontinuity caused by a long muscular subaortic conus. On a subxiphoid short axis view, we can notice the inlet ventricular septal defect which is remote from the aortic annulus. However, in the pathway from the left ventricle through the VSD up to the aortic annulus, there are no tricuspid valve caudal structures. On a three-dimensional echocardiogram, where we lay open the right ventricular septal surface, we can appreciate that the ventricular septal defect is far remote from the aortic annulus. The aorta and the pulmonary arteries have been labeled. The arrow marks point to the region of the aortic annulus. The ventricular septal defect is located in the inlet septum. However, through a long intraventricular tunnel patch, we will be able to route this inlet ventricular septal defect towards the aortic annulus, since there are no tricuspid valve caudal structures which are attached to this subaortic area. Remote ventricular septal defects can be located in inlet septum or in trabecular muscular septum in patients with double outlet right ventricle. On this subxiphoid short axis view, we can appreciate a remote ventricular septal defect. However, it's not in the inlet septum, but in the high trabecular septum. We can notice a long separation from the ventricular septal defect towards the aortic annulus. However, there are no tricuspid valve caudal structures in this prospective intraventricular tunnel pathway. A modified subxiphoid view which shows that even though the aorta and the ventricular septal defect are at far remote areas, an intraventricular tunnel closure is possible. On a three-dimensional echocardiogram which lays open the right ventricular septal surface, we can notice that this ventricular septal defect is located more cranial and basal to the region of the inlet septum. Even though there is a long separation from the aortic annulus, intraventricular tunnel closure of the VSD towards the aortic annulus is feasible. We noticed in this presentation there is a substantial added advantage of utilizing three-dimensional echocardiogram to guide the surgical strategy in patients with double outlet right ventricle. So by three-dimensional echocardiogram, we can stratify double outlet right ventricles as those with subaortic ventricular septal defect, where the VSD can be closed to route the LV towards the aorta. Subpulmonary VSDs, where the VSDs can be closed to route the left ventricle towards the pulmonary annulus and subsequently perform an arterial switch operation. DORVs can also be classified as remote but routable ventricular septal defects and remote and non-routable ventricular septal defects. This is the right ventricular septal surface seen en face. After cropping off the right ventricular anterior free wall and exposing the entire right ventricular surface of the interventricular septum, we can appreciate the aorta and the pulmonary artery and a large subaortic VSD located above the septal band. This is an example of a double outlet right ventricle with a large subpulmonary VSD. Contrary to the previous example, we can see that below the aortic valve, the ventricular septum is intact. The coronal septum has fused with the posterior division of the septal band, and the ventricular septal defect is located below the pulmonary annulus. We will be able to route this subpulmonary VSD by putting a patch around the VSD margins towards the pulmonary outflow tract. A subsequent performance of an arterial switch operation will complete a biventricular repair. Double outlet right ventricle with large subpulmonary ventricular septal defect, otherwise called a Stausigg-Bing anomaly, may also be associated in about 10 to 20% of the patients with additional muscular ventricular septal defects. In this example, you can appreciate a large inlet muscular VSD along with a large subpulmonary VSD. We will demonstrate the double outlet right ventricle with a large subpulmonary ventricular septal defect with 2D echocardiogram and show the additional value of 3D echo. Subxiphoid short axis view shows a double outlet right ventricle with anterior aorta and posterior pulmonary artery, a large subpulmonary VSD with about 50% of pulmonary annulus overriding the ventricular septal defect. We can notice the pulmonary mitral fibrous discontinuity. On this apical view, we can appreciate both the aorta and pulmonary artery arising from the right ventricle. The pulmonary artery is considerably overriding the ventricular septal defect. On a parasternal long axis view, again we appreciate 50% override of the pulmonary valve. The entire aorta is seen anteriorly. The parasternal long axis view shows the tricuspid valve and the aorta on a rightward sweep. The aorta is right and anterior and the pulmonary artery is left and posterior. On a 3D echo, when the right ventricular septal surface is shown by cropping off the anterior free wall of the right ventricle, we can appreciate the large pulmonary annulus and a large subpulmonary ventricular septal defect. Double outlet right ventricle with doubly committed VSD refers to ventricular septal defects which are located below both the aortic and pulmonary valves. This is relatively rare compared to double outlet right ventricles with subaortic and subpulmonary VSDs. In this subxiphoid short axis view, we can notice the aorta arising partially from the right ventricle. There is a 50% aortic override. On a leftward sweep on the same subxiphoid short axis view, we can appreciate the pulmonary valve giving off the dilated the main pulmonary artery. We notice that there is no conal septal tissue between the aortic and the pulmonary annulus, and the VSD is related to both the aortic annulus and pulmonary annulus. On a parasternal long axis view, we can notice the aortic root and the override of the aorta across this ventricular septal defect. The aorta and pulmonary artery have a side-by-side relationship. Both the valves are trileaflet. The branch pulmonary arteries are dilated due to large flow into the pulmonary outflow tract. So far, we have seen multiple examples of double outlet right ventricle with subaortic subpulmonary VSDs, remote muscular and remote inlet ventricular septal defect, and the rarer doubly committed ventricular septal defects. All the defects in double outlet right ventricles so far described were very large and comparable to the sizes of aortic annulus. When the ventricular septal defect is smaller than the aortic annulus, they become restrictive and they lead to left ventricular systolic pressures higher than the aortic systolic pressures. An example of a double outlet right ventricle with a restrictive subaortic ventricular septal defect which causes a subaortic stenosis. We can notice that there is a mild left ventricular systolic dysfunction and the left ventricle is mildly dilated. A small subaortic ventricular septal defect is shown. The size of the VSD is much smaller than the aortic annulus. On a parasternal long axis view, we can notice the turbulent color flow from the left ventricle towards the aortic valve, indicative of higher pressures in the left ventricle than the aortic systolic pressure. On this parasternal long axis view, we can appreciate that the ventricular septal defect is much smaller than the dilated aortic annulus. The subaortic conus is also mildly hypertrophied and The restrictive ventricular septal defect with the hypertrophied subaortic conus cause a significant subvalvar aortic stenosis. On a subxiphoid coronal sweep, we can notice the right ventricle, the subaortic area and the subpulmonary area. The relationship of the great arteries is normal. The aorta is right and posterior, the pulmonary artery is left and anterior, and there is a thick conal muscular structure located in the subaortic area. On a 3D en-face view of the right ventricular septal surface, we can notice a small restrictive subaortic ventricular septal defects. It's important to recognize restriction of these ventricular septal defects since the VSDs will need enlargement during performance of an intraventricular tunnel patch closure of the VSDs. Remote ventricular septal defects will need very long intraventricular tunnels to be constructed towards either the aortic or pulmonary outflows. A subxiphoid short axis view shows a very large ventricular septal defect located in the inlet septum between the tricuspid and the mitral annulus, which is far remote from the aortic annulus. However, we can notice that this ventricular septal defect can be routed towards the aortic valve through a long tunnel without disturbing the tricuspid valve apparatus. Some of the problems that will be posed for routability of ventricular septal defects will be hypoplasia of the right ventricle. In some patients, the tricuspid annulus and the right ventricle may be hypoplastic and they may limit performance of an intraventricular tunnel closure. Straddling atrioventricular valves is yet another reason that may pose problems for routability of ventricular septal defects. Apical 4-chamber view of this patient with large secondary atrial septal defect and a remote ventricular septal defect, we can notice that there is a right ventricular hypoplasia. A subxiphoid coronal sweep, long axial view showing a large inlet ventricular septal defect with straddling of the tricuspid valve. We can see the tricuspid valve caudal apparatus attaching to the crest of the interventricular septum. This straddling of the tricuspid valve in inlet ventricular septal defects will also make it difficult to route the ventricular septal defects towards aorta or pulmonary annulus. We can also notice that there is a left juxtaposition of the right atrial appendage, which is a common association in patients with Taussig-Bing anomaly. Many hearts with tetralogy of Fallot morphology may have features of double outer right ventricle and manifest aortomitral and pulmonary mitral fibrous discontinuity. A parasternal long axis view of a patient who had clinical features of tetralogy of Fallot, we can appreciate a small aortomitral fibrous discontinuity, a thick subaortic conus that is separating the aortic annulus from the anterior mitral annulus. So this will be called as a double outlet right ventricle. On a leftward sweep of this parasternal long axis view, we can appreciate a severe infundibular narrowing and turbulence in the subpulmonary outflow tract. On a parasternal short axis view, we can appreciate the severe infundibular narrowing, side-by-side relationship between the aortic annulus and pulmonary annulus, the narrowed pulmonary outflow tract. We can also see that the right coronary artery is giving off the left anterior descending coronary artery and the LAD crosses the right ventricular outflow tract in the region of the infundibulum. A close view of the aortic root demonstrates the right coronary artery arising from the anterior sinus. The big left anterior descending coronary artery comes off as a branch from this right coronary artery and crosses the right ventricular infundibulum anteriorly. To summarize this module on double outlet right ventricle, double outlet right ventricle can be defined under override criteria of both great arteries or the presence of bilateral conus. In DORV, the VSD can be subaortic, subpulmonary or doubly committed. Sometimes the VSD can be remote to both the great arteries and located either in inlet location or trabecular muscular location. The relationship of the great arteries are commonly side by side, but any relationship of great arteries can occur in DORV.